Good evening, everyone. So this week we'll be discussing Lichen Planopilaris. So for the past multiple weeks, we have been discussing hair as an organ, and now we are discussing hair disorders. Now, understand that last week we discussed the pathophysiology of alopecia areata, and we discussed a bit about the prototypic disorder of non-scarring alopecia. So I thought that this week we'll be discussing the prototypical disorder of scarring hair loss, which is lichen planopilaris. Now let's look at the name first. The lichen plano part comes from lichen planus. Okay, so lichen planus and pilaris means hair. Okay, it's a root word for hair. Now essentially, lichen planopilaris means follicular lichen planus. Isn't it lichen planopilaris, lichen planus of pilaris, or lichen planus of hair? But as we will go on and discuss more about lichen planopilaris, and in the later part of the video, especially for members, you will understand that there is a considerable overlap between lichen planopilaris and what we term as follicular lichen planus. Lichen planopilaris was initially described as follicular LP. It is still described. In fact, Rooks' 10th edition mentions it under the subheading of follicular LP. But there can be subtle differences. For example, I personally regard follicular LP as lichen planus like plaques surrounding the follicles on other parts of the body. And if we take a biopsy from those papules, we will see a lichenoid infiltrate surrounding the follicles. If the same thing is present on the scalp, a term as lichen planopilaris should be used. However, the other school of thought or majority of the people would like to think that lichen planopilaris can involve scalp along with other body areas too. Okay, but then if we discuss a bit about Gram-Little Picardy-Lasser syndrome, and which we will discuss in the later part of the video, we will understand that LPP, when we talk about LPP or lichen planopilaris, we're talking about involvement of the scalp only. Okay, while the other body part involvement should be deemed a bit separate from lichen planopilaris, and terms like Gram-Little Picardy-Lasser syndrome or follicular LP would be a better term to discuss these disorders when they involve other parts of the body. However, for this lecture, if we are saying lichen planopilaris, we're discussing about the disorder which affects scalp strictly. So with that background, let's start a discussion on lichen planopilaris. Now, as we have said that it is another term is follicular lichen planus, but we have had a discussion on whether we should term it as follicular lichen planus or not. It's an uncommon inflammatory scarring alopecia. Remember, it's an inflammatory mediated disorder which leads to scarring hair loss. So last week we discussed about alopecia areata that was non-scarring. There was no scarring in that. It is a type of, or an example of primary lymphocytic cicatricial alopecia. That means the major infiltrate in the disorder are the lymphocytes. Okay, and if you read books regarding the classification or histological classification of alopecias, the classification goes like lymphocytic, neutrophilic, mixed, infiltrate, and others. So that's how we divide folliculitis or cicatricial alopecia histologically. So lichen planopilaris is an example or a prototypic example of primary lymphocytic cicatricial alopecia. LPP leads to patchy and scarring hair loss. We know about that the hair loss will be scarring. What essentially happens in LPP? There is perifollicular inflammation and follicular hyperkeratosis. That means if this is the hair canal and this is the hair shaft, okay, a very rudimentary diagram, but bear with me, you will have inflammation around the follicles, perifollicular inflammation, and hyperkeratosis or increased keratin deposition in the hair canal. Okay, so follicular hyperkeratosis and perifollicular lymphocytic inflammation is what actually drives LPP. Let's move forward. Now, the types. LPP essentially, what we think of LPP, we're thinking of classic LPP. Okay. Other disorders like Gram-Little Picardy-Lasser syndrome or frontal fibrosing alopecia or fibrosing alopecia in a pattern distribution have now been termed as variants of LPP. Okay, so for this lecture, when we are talking about LPP, we are talking about classic LPP. But gram-little Picardy Loster syndrome, frontal fibrosing alopecia, and fibrosing alopecia in a pattern distribution have now been clubbed together with Lichen Planopilaris as the variants of Lichen Planopilaris. Okay, we'll be discussing variants in a separate short video, which I will make it available for members only. Let's move forward. Women are most commonly affected with LPP, especially at perimenopausal menopausal age group. The female to male ratio is about 2 to 3 is to 1 to as high as 13 is to 1. So majorly affecting women like any autoimmune disorder. The onset is early to mid 50s and it may start with symptoms like itching, pain or burning sensation, and they have been reported to be in as high as 60% of patients. So it's a good idea that when you're taking history regarding LPP, you should ask about any preceding symptoms of itching or any irritation over the scalp, which might give you a clue that some kind of inflammatory damage has led to this kind of cicatricial alopecia. This is a good way to differentiate between atrophy in an alopecia patch. Let's say a patient comes with you with alopecia and there is atrophy. Now that could be because of intralesional steroids or topical steroid application, and the case would be just alopecia areata, a non-scarring type. A good idea to differentiate would be to ask if there's any itching or pain or burning sensation before the alopecia started. And if there is, then it points you towards more towards inflammatory scarring alopecia. Okay. Now remember, this kind of itch, pain, or burning sensation can also be in the initial stages of alopecia areata, but it is mostly linked with cicatricial alopecia because a lot more inflammatory damage is going to occur in scarring alopecias. Now, about 2 to 50% of patients will have additional finding of mucocutaneous LP. Now, remember this rule. If you have a lichenoid disorder, like lichen planus or lichen planopilaris or lichen planus pigmentosus, always examine other sites for lichenoid disorders. So if you have LPP on the scalp, examine the oral cavity for oral lichen planus or wrist, ankles for lichen planus. Okay. So you need to examine other sites for other lichenoid disorders. These disorders tend to occur together. So you might miss another lichenoid disorder just because you're looking only at the scalp. It is associated with other autoimmune disorders, most commonly by thyroid disease, autoimmune mediated thyroid disease in about 30% of the patients. Hormonal derangement like androgen excess and PCOS have been implicated to occur with lichen planopilaris. Now, one thing to understand is that hormonal derangement was not found to be a major association with frontal fibrosing alopecia. So that's a point differentiating frontal fibrosing alopecia as against with lichen planopilaris. Clear? So in frontal fibrosing alopecia, the hormonal derangement has not been shown to be that linked, but it is found to be linked with lichen planopilaris. Let's move forward. So we have told you that it is a prototypic example of primary lymphocytic cicatricial alopecia. That means the inflammation will be driven by lymphocytes. It is Th1 mediated interferon gamma driven inflammation. Okay. So Th1 mediated interferon gamma inflammation around the bulge area. Now this bulge area is important. Why? Because Th1 derived interferon gamma inflammation was also seen in alopecia areata, but in alopecia areata it was around the bulb, the lower portion, the bulb. But here the inflammation is targeting the bulge area, and we know that the bulge area has a lot of stem cells. Okay, if you want to go into further discussion, look at our video on anatomy of anatomy of hair and also hair cycle. So you will understand that the bulge area, that thickening of outer root sheath cells, they have a lot of stem cells and they are required for continuous cycling of hair from anagen to catagen to telogen. Now, if these stem cells are damaged by interferon gamma driven inflammation, the hair follicle will not go into a cycle. It will stop growing and it will not be able to regenerate, leading to scarring alopecia. In alopecia areata, the bulb cells are damaged, the stem cells are preserved, so the hair can grow back. Okay, if it's not late stage, it can grow back. Clear? Now there is loss of keratin 15 positive, CD200 positive hair follicle stem cells. Now when these cells are lost, this could be a part of immune privilege collapse. Remember, we have discussed immune privilege quite extensively last week while discussing alopecia areata. When immune privilege collapses, it leads to a cascade of inflammation. We know that hair follicle is an immune privilege site. It protects itself from the immunity of the body. But if that barrier, that wall is broken, the immunity will attack the hair follicles and there will be hair follicle loss. Okay. Cells like CD8 positive T cells, CD123 positive interferon secreting plasmacytoid dendritic cells are also increased. These are the same cells that we see in alopecia areata, but remember now the damage is at the level of stem cells. Indifferent gamma-inducible CXCR3 binding chemokines like CXCL9 and 11 are also increased. Now these are all chemokine markers. And what is a chemokine? Chemokines are those chemicals which are responsible for stimulating immune cells to travel. Okay, so they are kind of calling the immune cells to reach the hair follicles. All of this inflammation leads to immune privilege collapse. Now, the same problem arises with alopecia areata and Lichen Planopilaris. We don't know what came first, the chicken or the egg. Whether immune collapse led to inflammatory damage or inflammatory damage led to immune collapse, we cannot be much surer about it. But remember, a single immune privilege collapse or a single trigger of immune collapse can lead to a cascade of inflammation and they can lead to hair loss. If that inflammation is around the bulb, it leads to alopecia areata. If it's around the stem cells, or sorry, the bulge area, it leads to lichen planopilaris and thus scarring alopecia. Let's move forward. Okay, so in lichen planopilaris, we know that there are discrete patchy scarring alopecia. Okay, so there are discrete patches of scarring alopecia. They have irregular margins. Okay, they have irregular margins and they are interconnected. Okay, by interconnected, we mean that a patch could be hair, then hair, hair. So interconnected patches of scarring alopecia. Most common sites are the crown or the vertex, the top of the head. The lesional scalp could be pale, mildly atrophic, okay, and other areas, for example, other areas of the scalp can easily be involved in 10% of the cases. There is perifollicular redness. Why? Because infiltrative damage is happening and follicular hyperkeratosis around the follicles. We have discussed them in the introduction of the slide. There's a pattern known as confetti pattern in which if this is the entire scalp, okay, if this is the entire scalp, we're looking from the top, then you have multiple small patches of alopecia in a network-like pattern. So that is known as the confetti pattern. So multiple scarring alopecia patches, small patches, about 1 to 2 centimeter wide, a lot of patches over the top of the scalp. Okay, so this is the confetti pattern of lichen planopilaris. Let's move forward. We know that the presence of pruritus, burning, and discomfort shows inflammatory activity, and it can be there in patients. So we need to ask about it. Loss of eyebrows, eyelashes, well as facial hair is extremely rare, about 1 to 2.7%. But loss of eyebrows, eyelashes, and vellus hair are more common in frontal fibrosing alopecia. So this is another differentiating point between frontal fibrosing alopecia and lichen planopilaris. Associated LP is about 2 to 21 to 50%. 28% have been mentioned in Fitzpatrick. So you can quote any of this data because 2 to 50% is a very wide range. Okay, so 28% according to Fitzpatrick have an associated lesions of lichen planus elsewhere. Now look at this picture which I've taken from Fitzpatrick, page 1527. It shows central scarring alopecia with fibrosis. You might not be able to appreciate much fibrosis, but look at how this area is reflecting a lot of light. Usually skin is not reflective that much. It absorbs a light and the reflection is usually happening on multiple levels. The surface of the skin, the dermis. In fact, the dermoepidermal junction also reflects light. So because of this kind of different layers of reflection, normal skin has a very hazy reflection. But when it is thinned out, it's atrophic, it becomes more reflective. So this area is more scarred, okay, more fibrotic, and we can see hair loss, patchy hair loss over the scalp. Let's move forward. Now this picture I've taken from Rooks, and you can see that there is perifollicular scaling here. You can easily appreciate the scales which are present in the picture. The central area of the scalp is white. You can see this white area here. You can see multiple irregular white area here. These are all scarred areas. The white area shows the absence of proper blood flow because the dermis there is very scarred. So white areas are scarred. The redness that you observe is usually in the periphery of the lesion. Okay, perifollicular lesions, that means the hair shafts present in the periphery of the scarring alopecia can have perifollicular erythema because of ongoing inflammatory activity. But the central part of the lesion will show pale scalp because it is atrophic. Now this is from Bolognia, and you can easily appreciate loss of follicle openings. So normally in the normal scalp you will see multiple dots. If I change the color, you will see multiple dots like one hair, one hair, one hair, one hair. These are normal follicular openings that we see. But in Lichen Planopilaris, these follicular openings have lost. It is because of scarring. The follicles have been closed together. The pore, the ostia, the hole through which the shaft comes out has been gone. It's gone because of intense scarring. Okay. So this area has completely scarred. You can easily appreciate the loss of follicular openings. Let's move forward. Now this is a trichoscopic image. Trichoscopic just means dermoscopy of the scalp. And you can see that the follicles openings have been lost. You cannot see a normal follicles opening. Another thing that you can see is perifollicular scaling or parakeratosis. Now, parakeratosis could be a response to inflammatory damage, and like in planopilaris. Okay, so this kind of perifollicular scaling with erythema and interfollicular epidermis showing scarring is what you see in trichoscopy. Now, differential diagnosis include alopecia areata, but the lesion has to be non-inflammatory. There should not be any atrophy. In LPP, you have atrophy, so that is one differentiating feature. Frontal fibrosing alopecia, which is now considered to be a variant of LPP. So we cannot actually say it's a differential diagnosis, it's a variant of LPP. But in frontal fibrosing alopecia, there is hairline involvement. So in LPP, there is lack of hairline involvement. Clear? And pseudopelade of Brock. We know that it's kind of an idiopathic or when we don't know the cause. Idiopathic scarring alopecia. So pseudopelade of Brock could be another differential. Let's move forward. Now, investigations, we can do trichoscopy to look at the features for diagnosing LPP. We can look at scarring, if it is present or not. Additionally, we can use trichoscopy to identify biopsy sites. So if you take a biopsy from the scarred area, you will just see a scar. You will not see anything. So it's better to do a trichoscopy of the surrounding region and see where it is more parakeratotic or more inflammatory or more red. Take a biopsy from that site and you will find good enough features on histopathology. So biopsy has to be taken from an actively inflamed hair-bearing skin at the edge. And biopsy has been termed as the most reliable and the accurate investigation for LPP. You need to take a biopsy from the edge in LPP. Mucin deposition is usually absent, but I will show you some photos in which mucin could be seen. So mucin happens when fibrocytes are getting damaged. Okay. And presence of mucin is more towards DLE. But that doesn't mean that mucin cannot be seen in LPP. It can be seen because fibrocytes can be damaged because of inflammation that is happening. But in DLE, the level of inflammation is so much that you have a lot more mucin deposition. So you can actually use this factor. If there's a lot of mucin, the biopsy goes more towards DLE, which is another cause of scarring alopecia. So on biopsy, you can differentiate these two disorders. You can do direct immunofluorescence to show IgM staining colloid bodies in the peri-infundibular ischemic region. But we rarely do DIF. It's a histopathological diagnosis of simple HNE. So on histopathology, in the early lesions, you will see vacuolar interface change or vacuolar interface damage. with moderately dense perifollicular lichenoid infiltrate at the level of infundibulum and isthmus. Now remember, we need to target the bulge region, and that bulge region is just you could say just below infundibulum. Let me just make it again. Just below infundibulum. Sorry. Yeah, just below infundibulum and isthmus. Okay, so all the inflammatory damage, if it is targeting the bulge area, it will be present a bit higher up in lichen planopilaris. Otherwise, in alopecia areata, it's more towards the bulb. Clear? There's lichenoid infiltrate in interfollicular location also. That is not sacrosanct. Mostly it is seen around the follicles, but in between the follicles, you can have lichenoid infiltrate. In late stages, you will see loss of elastic fibers in superficial dermis. You will see a wedge-shaped scar. Why? Because the entire follicle is now been replaced by a fibrotic scar. So you will see a wedge-shaped scar. Clear? This loss of sebaceous glands because of the inflammatory damage. Let's move forward. So this is a schematic representation of what actually happens. You have the hair follicle with associated apocrine gland, sebaceous gland, erector pili muscle. Okay, so there is the hair bulge, which is just at the level of below the level of sebaceous gland opening. Now there is lymphocytic infiltrate around the hair follicle at this level, so it's a bit higher up as compared to alopecia areata, and because of this inflammatory damage, you have a wedge-shaped scar. So that's what we're trying to tell you about wedge-shaped scar. Now look at this biopsy, which with the photograph I've taken from Rooks. You can see that the infiltrate is mostly centered around the hair follicle. It is spilling into the interfollicular region, but this is more or less spared. Okay, the interfollicular region is more or less spared. The majority of the inflammation is around the follicles. In fact, you can easily see a follicular plug here. Okay, follicular plug is just blockage of the hair canal because of intense hyperkeratosis and scaling. So this is follicular plugging. Okay, the follicular plug is better seen here. Also, I've taken this picture from Whedon's page 59, and it also shows very beautifully the perifollicular lymphocytic infiltrate. I think the image has been enhanced a bit, but here you can easily see the perifollicular lymphocytic infiltrate with a good amount of follicular plug. In fact, you can appreciate a bit of interfollicular, okay, interfollicular lymphocytic infiltrate. Clear? Let's move forward. Now, we can see the perifollicular infiltrate, which can extend to involve the adnexa also and become periadnexal infiltrate. So this all inflammatory cells that you can see here, all the purplish circular cells, these are nothing but lymphocytes. Okay, you can see damaged keratinocytes. This damage is because of inflammatory damage due to lymphocytes. And you can see that damaged cells are leaving behind empty spaces, which is the vacuolar change. Okay, now this kind of vacuolar change is seen. Imagine you are just looking at a slide of lichen planus. The only difference is that now everything is happening around the hair follicles only. Okay, so you will see vacuolar damage of the basal cells, you will see apoptotic keratinocytes, you will see intense lymphocytic infiltrate around the hair follicles, and that is a biopsy of lichen planopilaris. Let's move forward. So here again, you can see a lymphocytic or lymphocyte-rich infiltrate surrounding the follicles. There is a little bit of inflammatory infiltrate around these vessels also, but the reason that I took this picture is that in slides in his biopsy of DLE, you also have perivascular lymphocytic infiltrate, but it is much more as compared to lichen planopilaris. In lichen planopilaris, you can have perivascular inflammatory infiltrate, but in DLE you will have perivascular lymphocytic infiltrate. You will have intense infiltrate in DLE. You will have intense mucin deposition in DLE. You will have involvement of the upper, mid, and lower dermis in DLE, while in Lichen planopilaris, the perivascular lymphocytic infiltrate will be a bit less, if at all present, and you will not see much mucin, and you will not see the involvement of the entire dermis because of inflammation. It will be restricted around the upper follicular end. Okay, and in this picture, you can see deposition of fibrocytes because of fibrosis that is happening around the hair follicle. Okay, so here also you can see fibrosis. Now, these pictures are taken from pathology outlines. The link would be in the description. You can individually go there and see. Now, the management part of LPP is actually the easiest part. Why? Because we know that inflammation is going on. We need to manage inflammation. To measure LPP, you need to do serial photography so that you can look at the plaque, you can see how it is progressing or how it is improving, whether there's any hair growth or not. You can also do measurements like you do in any area. You can use a graph, you can use computer applications, you can use measurements over the photograph. You can have the longest and the shortest diameter, all sorts of things just to measure the plaque and see if it is progressing or not. One scale that I would like to mention is Lichen Planopilaris Activity Index. In this index, it is somewhat similar to what we know as PASI in psoriasis. Okay, so this index is a clinical index which includes symptoms, signs, disease activity, and spreading of the plaque. And you assign values, assign numbers to each of these factors, and then add them together. And that is your Lichen Planopilaris Activity Index. It tells you whether it is active or not. So I thought I'll just mention the name. So management is by suprapotent topical steroid scalp applications, which is the easiest application to start with instead of systemic therapies. The intralesional steroids, HCQ, both have the first line treatment of lichen planopilaris, and second line include methotrexate, mycophenolate mofetil, cyclosporin, all the immunosuppressive drugs. Okay, just a second. Yeah. So all the immunosuppressive drugs. Systemic steroids are used very rarely in lichen planopilaris, and it is used to control rapidly progressive disease, a disease which is progressing so fast. Okay, so like any inflammatory disorders, which we have already discussed while discussing vitiligo, that you need to stop the progression of disease first. Okay, the hair wants to grow, but the immunity is not letting it grow. So we need to stop inflammatory damage because of immunity. The hair will come back. Okay, so if the disease is very fast in its progression, you may like to use systemic steroids to control it first and then maintain on immunomodulatory drugs like HCQ or apremilast or JAK inhibitors, or in fact only topical steroids, but you need to stop the progression first. Now, pioglitazone is a PPR gamma agonist. And we have discussed, especially for the members, because that part will be available to members only, that PPR gamma levels have been found to be reduced in LPP. So if you give treatment in the form of pioglitazone, which is an agonist, it has been shown to have varying success in different articles. Some say successful, some say not so much. Okay. Other treatment like tetracycline antibiotics, oral retinoids, PRP, low-level light therapy, all have been tried with varying success. JAK inhibitors like tofastinib, oral, topical, both have had some substantial immune response, but should be used as a good maintaining agent. If the disease is progressive, personally, it's a personal suggestion, okay, personal opinion, that's better to start with steroids, either topical, intralesional, or systemic. If the progression is still present, first we need to stop the progression and then maintain maybe on JAK inhibitors. Hair transplantation can be considered when we are very sure about the stoppage of progression. Okay, the disease has to be non-progressive to even consider hair transplantation. There have been cases of frontal fibrosing alopecia and lichen planopilaris after hair transplantation, so we need to be very careful. Okay, but that is one level of management in long-standing cicatricial alopecia, which has shown no sign of progression for a long period of time. So this table I've made from this article, it will be mentioned, it will be there in the description. Therapeutic management of classic lichen planopilaris, a systemic review, which shows that level of evidence for HCQ and methotrexate is level 2, while all the other modalities, okay, all the other modalities like oral tetracyclines, cyclosporin, MMF, intralesional corticosteroids, okay, oral retinoids, oral steroids, glycofulvin, these are all level 4, level of evidence 4. Okay, HCQS has shown to have more effect in erythema, while methotrexate showed more effect on all parameters. So there was good improvement in all parameters. But remember, HCQS is somewhat of a safer drug as compared to methotrexate. You might would like to use first methotrexate and then switch to HCQS as a maintaining agent. Okay, so these two drugs are good agent and they have good level of evidence in systemic reviews. Now, JAK inhibitors do have a role in interferon gamma signaling. It's big. See, interferon gamma signaling, which is a prototypic example of Th1 response and activation of CD8 positive cells, is mediated through JAK-STAT pathway. So if you inhibit that pathway, this kind of inflammatory stimulation doesn't occur. That is why we use JAK inhibitors for a lot of immune-mediated disorders. So they do have a role. In fact, oral tofacitinib, topical tofacitinib, baricitinib have all been tried with varying success. There have been much mention about stopping JAK inhibitors, but the disease relapses. So, in my opinion, JAK inhibitor becomes a good maintaining agent. You stop the progression with drugs like methotrexate, corticosteroids, and then maintain JAK inhibitors. Okay, oral JAK inhibitors are found to have much better response as compared to topical, which makes sense, isn't it? Let's move forward. Now, with that being said, these are the reading recommendation. I mentioned the chapter numbers. I've all of these different articles will be mentioned in the description below. And if you want, you can just read. If you are more interested into individual aspects of lichen planopilaris, you can read about it. With that, again, shameless plug, do consider becoming a Ruby member at least. If you find these videos to be helpful, you will have access to members only videos which are longer. They have detailed slides, they have extra information, they have additional information regarding the content, and slowly, you will have access to better made videos. Not better made videos, but you will have access to more information to better understand and develop concepts about the topics that we are discussing. Okay, so do consider, and if possible, do consider becoming a Sapphire member. That's a one step above Ruby membership, and you will have access to all the videos and you will be the videos will be made available to you as soon as they are uploaded. Okay, you will have priority reply to comments. You will have exclusive polls to decide newer topics. Any suggestions would have a priority. So the priority would be given more as compared to a Ruby member, and definitely more as compared to non-members. So with that being said, do consider taking some time out and becoming a member of the channel. That gives me intense motivation to take on new difficult topics and make videos week after week. With that being said, I will finish this video now. Thank you very much for listening to this topic on lichen planopilaris. Now, in our OPD, whenever we have scarring alopecias, the disorder is somewhat clear cut. We don't have any problems in diagnosing. But it's better to go into the depth. You examine each and every patient, you examine for other areas for lichen planus, you examine the perifollicular area for erythema, you get a biopsy done, if not possible, get a trichoscopy done. So this is how you learn. You learn while talking to the patient, you learn while examining the patient, and if you have seen something with your own eyes, you'll remember. With that being said, I'll finish this discussion. You can email me anything on this email ID. It's a good idea to comment your doubts, suggestions, and queries just below the video in the comment section, and leave a timestamp so that I know what you're talking about. And other people who might come across this video can read your comments and my replies and learn from it. Maybe they have the same doubt. With that being said, I'll finish this video. Adios and bye bye.